Good afternoon, everyone, and welcome to the WebEx. Before we get started, I do want to go over a few of the housekeeping rules. As you can see on this slide, please change to the next slide. As you can see on this slide, to join the audio portion of the conference, dial 866-462-0164 and the password *974-7004 *. You should have received the WebEx link in your email. Just click on the link to be directed into the WebEx portion of this session. Please follow these instructions on this screen if you're having any difficulty logging in. Secondly, please be sure to enter your name, practice name, and number of participants from your practice in the chat window on the right. Also, please be sure to hang up and call back again if you do need to have us on hold. And also, please press the star key to raise your hand if you have any questions during the presentation. You should see at least the participant and chat panels on the right-hand side of your screen. If not, go to View menu at the top right portion of your screen, and you will click on the little arrow to add the chat window to be able to view the chat. Click on Chat or Participant and click on arrow to maximize or minimize. Please feel free to use the chat function at any time if you have any questions or care to provide feedback on best practices or share successes during the presentation. We will also have a question and answer session following our slides, and we'll be available to address any questions you may have through email as well. Contact information will be provided at the end of this presentation. We're going to go ahead and get started. So you guys are all are muted, and we'll reopen all the lines at the end of the presentation. Please do note that this is a live session and will be recorded and archived. I want to first thank all of you for joining us this afternoon for today's collaborative webinar on patient engagement. And now I would like to take a moment to introduce our speaker for this afternoon, Kevin Townsend. Kevin is a medical outcomes specialist with Pfizer, where he's involved in provider education and outcomes research activities. He completed pharmacy school at the University of Michigan and a pharmacy residency at Duke University Medical Center. Kevin's professional and research interests are in the areas of patient-centered medical home, cardiovascular disease, and medication adherence. And I'm going to go ahead and pass the presenter's role to Kevin, and Kevin's presentation is material is developed by Pfizer. Kevin, over to you.
Thanks, Mandy. We're going to start with feedback from our last session in just a second, but I do want to emphasize what Mandy was talking about as far as using the chat function. And we'll probably be pests about this during the workshop, but that's really how we make this even though we're doing this virtually, it's how we make it interactive. And while I'd like to think the information that we're giving on the slides is great and important, and it is, sometimes the best thing that you all can get out of these sessions will be what you read and see in the chat room, ideas, best practices, that type of thing, questions even that come up. So definitely want to encourage you to use that chat room. I also want to mention that Tanisha Browder-Smith is with me. She's one of my colleagues from Pfizer, working hard silently in the background. Tanisha is going to be monitoring our chat room and helping out with any questions and maybe facilitating discussion from time to time. So the other way that we'll be keeping the session interactive is by using some live polling. So you'll get a chance to vote a little bit later on in the presentation. So we can actually go to, we're right on the right slide here. Last time we asked everyone a question about how you start out with some self-management goal setting with patients, and that before you do that, do you actually start by thinking about the patient's stage of change. We talked about stage of change as kind of anytime you're asking a patient to make a change with regards to their health behaviors, they're probably going to be either pre-contemplative, contemplative, preparation, action, or maintenance, depending on what their current thought process is around that change. So we asked you all, how many of you really sort of consider that before deciding, am I going to give them more information, or do I want to jump right into a treatment plan or a prescription or a test or something like that? starting a new diet, anything like that. And it turns out that most of you, 42%, are actually doing that, which is great because obviously if somebody who's in that pre-contemplative phase, they're not really thinking or ready to start a treatment plan. Your goal with that patient is going to really be to get them from pre-contemplation kind of moving along where they're ready, they're prepared to take action and start a plan. So that was great. Very good news from that standpoint. And then next slide, we also asked them for some feedback about what do these different stages look like in your practice. From a pre-contemplative standpoint, one of the examples that was suggested was a patient with diabetes who would rather take medication than attempt to change their diet. So they weren't even really thinking or ready to start any kind of new diet or make modifications to what they like in their existing diet. Another example of a pre-contemplative patient with diabetes was somebody who, they didn't want to follow a diabetic diet because they thought that they were controlled, even though they had, some other issues going on, and they're starting a long-acting, short-acting insulin regimen, all the signs that they really needed to make some change, but they just weren't facing that, the reality of the situation. From a contemplative standpoint, one example that was brought up was somebody who was asked about wanting to quit smoking, and they responded, not ready right now, but ask them again in June. So they leave that door open. They're thinking about it. They have too much stress in their life right now, but they're ready to think about it, and they're inviting you to revisit that again. One of the ideas that came forward is that for a contemplative patient was calling patients monthly to take advantage of that potential readiness down the road, or at least revisiting it, making sure you make a note to revisit it at their next appointment. Then next slide. A preparation patient example that was brought forward was a patient with diabetes who agrees to decrease their carbs by 1 unit each meal and to check blood sugars daily. So they're taking a small step, maybe not ready to jump onto a large-scale plan or action plan, and yet they're taking small steps in the right direction. Someone who is in that action phase, perhaps the example that we received through you all was somebody who had a hospitalization because of an infected joint. Prior to that, their A1Cs ranged up in the 10 area. Now they're on their insulin. They're making diet changes. That hospitalization may have been that teachable moment, and now they're back in your office, and you have their A1C back into the 7 and 8 range. So that's somebody who's in a full-fledged action mode. We didn't have examples of the maintenance type of person, but really it's that the person who has taken those action steps, but now maybe they're slacking off a little bit. We did get an idea of what one office was doing to work with those types of maintenance patients. They had a care champion appointed in the office, and somebody who their job was to kind of line everything up for those patients, make sure that there were some follow-up calls being placed, some follow-up activity going on with that patient, and that there was a lot of support to make sure the patient had encouragement to stay in that action mode. So next slide, we're going to get you a little bit active right now, hopefully, using the chat function of the webinar here. Last time we asked you for an action item to pick one health behavior change technique and use it at least one time with one patient. So it could have been any of the things that we've talked about up until this point: rolling with resistance, trying to develop discrepancy. Remember we talked about the REDS acronym last time: rolling with resistance, expressing empathy, developing discrepancy, where you're trying to show the patient that the actions or the patterns that they're currently in right now aren't really aligned with the goals of avoiding problems down the road. Or supporting self-efficacy, where you're encouraging and giving positive feedback even for small steps the patient might take. So let us know in the chat room as we finish up this slide and move on that what have you done maybe in the last few months that would be consistent with motivational interviewing. So moving on to the next slide. I want to cover a couple other components of motivational interviewing that we didn't have time to cover last time. One of them is this concept of elicit, provide, elicit, or ask, tell, ask would be another way to phrase it, where it just sort of is the guide of how you structure your conversation with a patient. Think about the first step of any, initiating any directed conversation with a patient where you're heading down that road, either manage a goal or start a new goal, that type of thing, as eliciting or asking the patient for more information. Generally, these are going to be open-ended questions. So some of the verbiage, try to avoid that verbiage that leads into the yes or no types of questions. Ways I like to start questions to make sure, just because it's habit for me to ask yes or no questions. I'm sure it might be for some of you too. But some of the verbiage you start out with is, what do you think about? And that's generally going to wind up getting more information out of the patient. Or tell me more about. If you have to probe deeper on a certain thing a patient just said, or a yes or no response that they just gave you, if you slip up and ask a yes or no question and they say, yep, or nope, and that kind of leaves you wanting more information, standard kind of comeback is, tell me more about that. Tell me more about what we just talked about. So that's the elicit part of that. The patient's going to give you, hopefully, a good amount of information, maybe some things that you weren't thinking about that are specific to that case, that individual, that you can drill down on. And then at a certain point, if you go to the next slide, there's going to be that opportunity that we all are ready for, we're trained for, and that's why we're here, and that's the provision of information. Some clinicians, some staff would like to say, almost introduce it and say, would it be all right if I, give you some more background information on this topic now, or told you more about the medication we started, or would it be okay now if I gave you more details about the procedure we're asking you to do? The patient gives permission, and then you're able now to go into all the details that we're ready and able and wanting to give the patient. At the end of that, it's a good time to kind of circle back and just say, what other questions can I answer? And then finally, that sort of leads into the next slide, which is that eliciting again. And this, for any of you that are doing teach-back technique or have heard of teach-back, this is the time where the teach-back technique could really be, part of the conversation. It's just before you close out with the patient, asking them to teach back in their own words. A lot of times clinicians will start it out, or staff will start it out by saying, to make sure I didn't leave anything out, why don't you tell me in your own words how you're going to take this medicine when you get home, or how you're going to prepare for this test that we want you to do next week. So that's the teach-back technique, and it gives you that last chance to clarify any, slight misconceptions or errors that the patient had or misunderstandings, and avoid some potential problems in the short and the long term. So next slide, another part of any interaction, any office visit is going to be the patient with multiple issues, which are a lot of our chronic management patients. Perhaps most of the patients in your practice are going to have multiple issues going on, depending on the visit. Setting agenda and negotiating multiple behaviors is certainly a time management issue, if nothing else, and it requires some forethought. This can be addressed sometimes with that morning huddle or that staff huddle kind of concept, where if you know for the day who's coming in, you can look and budget time for certain patients, budget a little bit more time. But there's a lot more going on with this concept. It creates that negotiation concept with the patient. Think about that patient who may come in to your practice with a laundry list of things they're going to talk about, they want to get discussed. Not all of them are overlapping with what you need to get discussed. So it's that time to negotiate. And you say, okay, off of your list, what are the one or two things that are most important to you? So then that gets the patient buy-in, gets them stake in that visit and that time that they're spending together. And then it gives you the opportunity to come back and say, would it be all right if we also talked about how your blood pressure is doing, or your A1C values that we got back from your lab test? And you sort of reach that negotiated agreement with what the visit's going to look like. The patient goes home after the visit, kind of fast-forwarding, and they feel like they've not only gotten, what you wanted to talk about accomplished, but they've also they left with one or more of their items taken care of. A question that I like to keep in mind for these situations is, what concerns you most? So that will pull out not only what's important to the patient, but what is likely to be a barrier to that patient going forward, the thing they worry about, It could be something that's not really, from a clinical perspective, a high concern, a key concern or a key risk. But for the patient, if it's a high worry for them, if it's a high concern for them, it could be that barrier that prevents them from taking the medicine regularly or following through on a diet or exercise plan or some other change that you're asking them to make. So another option here is if you have two things that you think are both important, but you want to give the patient some buy-in, ask them, between, example with the last bullet, between exercise and diet, which do you think you'd rather start on or talk about first? So it gives the patient the ability to make a choice. Go to the next slide. Switching gears now, another idea or trick, if you will, associated with motivational interviewing is the readiness ruler. And a lot of times, you may have heard this already talked about in terms of assessing confidence level around a goal that you might have set with the patient. But you can also do this with importance. And I would encourage you to think about doing both depending on the patient. So it really is a way of checking importance and confidence, because it can be really two different things. I'll use two examples. One is a newly diagnosed patient with high blood pressure. They may be on no other meds, maybe a relatively young person who hasn't been on meds before in their life. If you ask them to tell you, what do you think, how important is this to you to start a medicine and change your diet and try and get your blood pressure down, they may rank it fairly low because it involves starting a new medicine, paying for a new medicine every month, maybe a side effect or two from the medicine, getting used to that, getting salt out of their diet, all of those types of things. So the importance might be low. Confidence-wise, they probably could say, yeah, I'm pretty confident I could take one pill once a day. But then that tells you as a provider that you have to work on the important side of it and get them thinking about and talking about, yeah, I do want to avoid, the problems associated with high blood pressure that could have come up in 5 or 10 years, the strokes, kidney disease, eye disease, that type of thing. And then the confidence, the other side of the coin is maybe an example would be somebody who is trying to quit smoking. They've tried 3 times in the past. It didn't work out. They know it's important, so they would give you a high score on importance, but they may not be very confident. And now it changes everything in terms of how you're going to work through the barriers with that patient. That becomes a confidence issue. You're going to talk about the previous trials and failures and how you can change things up a bit, try some new things, give them encouragement that, at least from a smoking cessation standpoint, it's quite common for patients to have failed quit attempts multiple times before they have a success. So the next slide, same concept here. They both get back to how ready someone is to quit. And if you go back and link some of these previous concepts together, someone's readiness, if they're pre-contemplative, maybe it's because they don't feel it's very important. Maybe because they feel they're not confident. As you address the specifics of importance or confidence, maybe you can move them from pre-contemplative to contemplative to preparation. So it's all about getting the patient ready to get into that self-management and that goal-setting mindset with you. Next slide is just a little more specifics on how you might go about doing this. You may use a scale and ask the patient to give you a number. If I had to ask, if you think it's a confidence issue, drill right down to that and ask them, on a scale of 1 to 10 or 1 to 7, how confident do you think you are in making this change? They'll give you a number. It's your opening now to get them talking more about that number. So if they give you a 3, so they're fairly low confidence, ask them why they chose a 3 and not a 1 or a 0. Now they have to actually verbalize, well, last time I tried to quit smoking, I got out to 3 weeks, so there was some success there, but then everything sort of fell apart. Work got crazy, I got stressed out, and I had to start smoking. So it gives you something to work on. And, you got them to at least 3 weeks, and now that's kind of your baseline. You can move forward from there. Then it also gives you the opening to talk about how to move forward. How can we get you to going to the next phase? What would get you to a 5 or a 6 in confidence? So that's the importance and the confidence scale. I would encourage you to use them as appropriately with your patients. New way to talk about barriers and how to get the patient more ready. Next slide. Pros and cons. I think we've all sort of use some of these techniques, and I think you've probably all used a lot of these techniques in the past, just maybe some new ways to think about them. Pros and cons, I just encourage you to have the patient talk about the pros and cons. Stay out of the teacher mode. Let the patient start talking more and ask them, you know, you can even say, I have in my own mind what might be the pros and cons, the risks and benefits of this change we're asking you to make. I'd like to hear your words, what you think might be the pros of making this change. The more the patient verbalizes the pros of something and is able to kind of compartmentalize the downsides, that's getting them from that pre-contemplative to contemplative phase. So if we go to the next slide, that's the examining the pros and cons. You can see some of the example questions you might ask. But again, stay out of that telling mode and have the patient sort of be the speaker as much as possible here. Next slide. Brainstorming, of course, we're going to be doing brainstorming. It's coming up with those shared solutions. I think what brainstorming on paper looks like, maybe for any of you that are doing action planning right now, you brainstormed with your patients. Action planning is getting that shared commitment or that shared plan of how the patient's going to get from point A to point B, how they're going to get from an A1C of 9 to an A1C of whatever that goal might be. So that's the brainstorming phase. Next slide. Talked a little bit about past successes and failures. I think for certain patients this is critical. If somebody has had a failure in the past in whether it be diet, exercise, smoking cessation, taking a med, going through a procedure, it's always worth revisiting that and explaining how that failure is not necessarily a guarantee that future attempts are going to go the same route. Great example is the smoker who's tried 2 or 3 times to quit and didn't work out. Coming back with some statistics that are out there readily available, you know, the average smoker will take 6 to 9 quit attempts to actually get a successful quit. So that sometimes is kind of that eye-opener for a patient. Doing a little more after you've kind of gone through some of these attempts, planted the seed, and you've had the patient maybe agree that, yeah, we can come back and talk about it later, I'm just not ready now. That's fine. It lets them know that you're not going to push them, and which would only cause them to dig their heels in more. So there is a time where you would do a little more. Hopefully not too often, but there's a time where you want to do that. Put the patient back into a comfort zone, preserve that relationship. Next slide. So I think I've talked a lot, and we're going to get you guys active a little bit again now using our polling feature on the webinar. So we'll start out with a case question. This patient on the case, Mr. Smith, says, well, there's several more things to remember to do each day. Some days I just forget to take my medicine, and now I need to remember all of the details of how to use these new inhalers appropriately. The goal with Mr. Smith is to instill the importance of his treatment regimen and to initiate a plan for improving his med adherence. So I'd like all of you to look through these responses. You can start figuring out which one is maybe the most appropriate one, most consistent with the motivational interviewing approach where you're working through the rolling with resistance, expressing empathy, developing discrepancy, and supporting self-efficacy. As you are considering these, I'll just kind of quickly run through them. A would be, well, you know, Mr. Smith, you're lucky to have survived your first heart attack. You don't want that to happen again, do you? Selection B would be, Mr. Smith, which medicines do you forget to take? Selection C, Mr. Smith, let's review the use of the new inhalers and why your meds are important. And then selection D would be, Mr. Smith, do you know why it's important to take all of your medicines? So I'm going to have Danielle go ahead and post the results. You can see most everyone chose selection C, I think that's a very good response. The people who originally created this material don't agree with you all and with me, but they have a good rationale why selection B is maybe also a very good response. If you said C, I'm going to give you credit for it. If you said B, which looks like none of you did at this point, I would also give you credit for that. Answer B uses that elicit tactic where you're gaining more information from the patient. Answer A it doesn't really serve to elicit a positive response, more combative. Answer C, which most of you are on board with, it implies that the main problem was with inhalers, which is probably, given the scenario, valid, but it also doesn't include the possibility that there's some other medicine that they're just not taking regularly for whatever reason. It could be cost, it could be a side effect, so you may actually have to sort of take a wider approach before you drill down to the inhalers. And then D, for those of you that might have answered D, it's a closed-ended question, remember. It's a yes or no, and you're giving that patient the option to say yes or no, and then you're going to have more work to do to elicit more response. So if we go to the next question or the next situation, so as the conversation with Mr. Smith progresses, you determine that he has a clear understanding of why he should take his medication and a clear understanding of the directions for the use, but that he has trouble remembering to take them, which is just forgetfulness is a very common root cause of medication adherence problems. Especially when he's feeling okay, there's no reminder for him to take the med frequently. So you have some ideas that may help Mr. Smith remember to take his meds. Which scenario serves as the least appropriate next step or strategy? So look through these four and pick out the one that would be least consistent with motivational interviewing. A would be, tell Mr. Smith you have a few ideas and suggestions that have helped other patients remember, and ask if you can share them with him. After you've shared them, ask Mr. Smith what he thinks of those suggestions. Would that be the least appropriate? Have the patient review the typical day to help you provide the best input in his care and how you could tailor, what you're doing and what your plan is with him. Option C would be promote Mr. Smith's confidence in his ability to take his meds as prescribed. Remember, the answer we're looking for is which one is the least appropriate. And then D would be ask Mr. Smith what is he going to do better to comply with taking his medications as prescribed. So you can see the responses coming in, and everybody is pretty much up on answer D as being the least appropriate. Danielle could go ahead and post those now. Answer D would be it's argumentative, makes Mr. Smith resistant, puts him on the defensive, so that would be the least appropriate. The other ones all have good concepts in one way or another of motivational interviewing, either asking permission to share, going through that typical day and eliciting response from Mr. Smith, or at the end, the last one, it's always a good idea to try and build that patient's confidence up and support self-efficacy. So, with that polling question done, we'll go to the next slide. And this is way too busy of a slide and kind of breaks all of the slide-making rules. But I put it up there because it has all of the elements, and we're going to ask you to chat a little bit now, enter some information in the chat room. And I wanted to have all of this sort of in front of you to kind of peruse and look over. Let us know in the chat function, and not only let us know, but let others know who are on the webinar. In what ways have you guys become involved in self-management goal setting, or more specifically perhaps motivational interviewing with your patients? So you can see it up at the top. Elicit, provide, elicit. That's that concept of trying to get the patient talking more and getting them having them address some open-ended questions up front so you can clarify what is specifically a barrier for the patient and not what you assume is the barrier for the patient. Another concept here is setting that agenda and trying to manage multiple behaviors. One of the biggest pushbacks to this whole topic really of self-management goal setting, using motivational interviewing is, where am I going to find the time in our busy practice to do all of these things? Well, the answer is you pick and choose your spots. It's for those resistant patients. It's for those patients with multiple chronic conditions that you're trying to work through. It's for the patient with maybe one chronic condition that they're just not really ready to make change around. That's when the motivational interviewing for a few minutes applied in the right time can be really effective and really helpful. But setting the agenda using working through multiple behaviors and negotiating would be a really good approach. And then down at the bottom, maybe you guys have already started experimenting with assessing confidence levels, or maybe now you're thinking about adding on assessing importance levels. How important is this to a patient? I think the importance question would be great when you have something that you really think the patient should consider and they're just not ready to do it. You guys can fill in the blank on what that change might be. But if you can get the patient assessing their own importance level, it's a starting point to move that conversation forward with the patient. So let us know if you can in the chat room. Enter a couple comments about what you're doing now around motivational interviewing or self-management goal setting. And we will get ready to move on to the next presentation. So let's go to the next slide. I just want to remind everyone that we will be, we'll be online for a few minutes even after the webinar ends. So if you have any other things you wanted to jot down and put in the chat area, we'll definitely be capturing these, and the folks at MPro will be making them available to you all. So you kind of have them as a reference to look back on as you're continuing to develop and evolve your own self-management programs in your office. Now I'd like to turn it over to our next speaker from MPro. I want to introduce Mandy. Mandy Cower is one of the clinical applications coordinators at MPro. She completed her bachelor's in business administration and information systems management from Wayne State University in Detroit, and she's recently finished her master's in public administration with a concentration in healthcare administration from Oakland University. She's currently working with MCEDA, and also she's the lead on the Prevention, Learning, and Action Network with MPro. So I'll turn it over to Mandy now.
Thanks, Dennis. For those of you who are joining us for the first time, I want to go over the MPro background. So who is MPro? MPro serves as the federally designated quality improvement organization for Michigan under contract with the U.S. Centers for Medicare and Medicaid Services. In addition to the physician office setting, the major area MPro works with are hospital settings, home health, and nursing home settings. MPro also performs independent dispute resolution, external quality review, and lastly, we have a beneficiary protection division. The work we do under this contract is called a scope of work, and it spans a 3-year period of time. One aspect of the current scope of work involves the Prevention, Learning, and Action Network initiative, and we call it the Prevention LAN. And this is why you all are here today. Next slide, please. I will provide a brief recap on our focus and participation requirements. The focus of this LAN initiative will be on improving patient and family engagement, assisting practices with clinical decision support and quality improvement, to foster a community of collaboration, and also to highlight best practices, interventions, and tools in preventive patient outcomes. Next slide, please. Prevention and participation can include, of course, the webinars, providing strategies and interventions, share successes and best practices via live WebEx, self-instruction module, which will instruct providers through online educational tools, and then technical assistance assisting with activities related to specific quality improvement questions, such as implementing quality improvement strategies at the practice level. Next slide, please. Program expectations are that you attend at least 2 educational sessions and complete a post-implementation survey, which will be available at the end of each presentation. So please stay logged in to complete this survey. We do take these evaluations very seriously, so we can improve our upcoming educational sessions. And also the active involvement also includes the implementation of strategies and interventions to address preventive measures. Next slide, please. Prevention is designed to coordinate and align with other CMS incentives, such as meaningful use, the clinical quality measures, physician quality reporting system in addressing similar measures as prevention, such as colorectal and breast cancer screenings, as well as immunization. Patient-centered medical home, which emphasizes preventive care and chronic disease management. The LAN also encourages providers to utilize a collaborative model demonstrating the PDSA, which is the Plan, Do, Study, Act cycle, as well as to share best practices and implement benchmarking tools at the practice level. So how do the prevention LAN measures align with meaningful use? Besides the clinical quality measures, the implementation of clinical summaries will help the practice achieve meaningful use as well as improve patient engagement. So, for example, clinical summaries help improve knowledge and understanding, helpful with decision making, and to improve the communication between patients and clinicians, and to change the health behaviors and improve self-management for health conditions, which ultimately leads to better health outcomes. Next slide, please. Okay, so we hear about the Plan, Do, Study, Act, the PDSA cycle, but what is it? How do we apply this in our healthcare setting? PDSA is essentially the actions where you develop a plan to test the change, you carry out the test, and observe and learn from the consequences, and then to determine what modifications are needed. You will have access to one useful resource that is available online is the Institute of Healthcare Improvement, the PDSA for Healthcare Improvement, and you will have access to these slides later. So if you can, I highly do encourage to check out this tool. It's a really good tool for PDSA cycle for healthcare improvement. Next slide, please. On this slide, I have listed a few local online community resources that have prevention-specific information. As I said, you will have access to these slides, and when you are in the slideshow mode, you will be able to, those active links are all active, and you should be able to go to these resources. These are very helpful resources. The community, our Department of Community Health has many great resources, and this is, as you can see on this page, this is just a screenshot of their Medicaid Department of Community Health prevention page, and it has great resources for engaging at the practice level, as well as providing tools to help educate our patients. Next slide, please. This is our website's AMPRO's prevention land page, and this new website will feature prevention documents and resources, as well as archived webinars and educational sessions to access at your convenience. So on left-hand side, like, you can't really see very well on this screenshot, but there are quarterly webinars, archived webinars, the sessions that have already happened. So you do have access to that material on our site. Next slide, please. Another great online resource is the website of the American Cancer Society, and they have listed some wonderful resources for the patient as well as for the providers. Here's an example of from their toolbox for clinicians to improve colorectal cancer screening in office. So it talks about how to improve cancer screening rates using the 4 essentials. The first essential, be clear that screening is important. Ask patients about their needs and preferences. Second, involve your staff to make screening more effective, as you do understand that this is not, this cannot be achieved alone. This is a collaborative effort, and the whole staff at the practice level should be involved. The third, simple tracking system will help you follow up as needed, such as tracking, being persistent with the reminders, tracking test results, and follow up with providers and patients. And then the fourth one, if you have not measured progress, you may not be doing as well as you think you were doing. So this is definitely a really useful tool to use. Next slide, please. And here are some additional online resources for breast and colorectal cancer screening, and they have tools for providers as well as patients. We're not going to go through these links, but like I said, I highly encourage, these are very useful resources, and you are able to click on these links and have access to those resources. Next slide, please. The National Institute of Health has also provided an extensive index of disease-specific topics. So, for example, Medline Plus has, index of disease-specific topics, the Health Topics Index. You can see very well on this slide, but that is, again, another useful resource. Next slide, please. Last, but not the least, don't forget to visit our resource page on the new AMPRO website. Here you will find more information about our Prevention Learning and Action Network, as well as other great resources such as how to apply for Governor's Award of Excellence in Prevention. Many of you love our Governor's Award of Excellence, so we do highly encourage to participate in that program. Next slide, please. So if you go to our site, you will see using this username and password, you are able to complete the registration form. You're able to see the Governor's Award of Excellence overview, what the award involves, what are the requirements, and then you're able to complete the online registration using this user ID and username and password. Next slide, please. So there are 3 steps involved to participate in the GEA program. There are materials online, the Governor's Award of Excellence, Governor's Letter. Then there's a step 2 is Prevention and Award Participation Overview Packet. And third, Prevention and Award online registration form. If you're interested in participating, you fill that on the registration form. Next slide, please. And here is our contact information. Please feel free to email or call if you have any further questions or just to share your successes. You may use the chat function as well for any questions or comments. And if we cannot get to your question today, I will be following up with you via email. And please remember to join us next time for our topic-specific prevention webinar on immunizations with guest speakers from Michigan's Department of Community Health. And more details will be provided as the date draws closer. I'm going to go ahead and open all the phone lines for any questions regarding today's topic, and we welcome your input. And you will be receiving the survey, the evaluation shortly. And please stay logged in to complete the evaluation. As I said, we do take evaluation seriously, so we can improve our upcoming sessions. And then, with that, your line should be all unmuted now, and so if you have any questions, please state in chat or just go ahead, state your questions so we can help answer. And you should have received the survey. If you can go ahead and please complete that, we'll really appreciate that.
Are we going to be able to print this PowerPoint?
Yes, you should be able to. Yes, that will be available to you, and you can print it out, or you're able to go on our website and also, access the archived webinars.
Okay, great.
And the slides, yeah. Any questions about the Governor's Award of Excellence?
I mean, if we just follow the PowerPoint, then we can apply appropriately, right?
Yeah. You should have, be able to see all the instructions online. And if you have any questions, of course, you're more than welcome to contact us, and our information should be listed, our contact information on the site as well.
Okay, great, thanks.
And we are going to email the slides to all participants for today's call as well.
Okay.
If there's no any other questions, we will be sending you all the invite for our next webinar, which is, is on immunizations, and we will have a guest speaker from Michigan's Department of Community Health on that webinar. So I want to thank all of you for joining us today, and we'll see you all at our next webinar. Thank you.